So I'm delighted to introduce Dr. Erickson. She is a board-certified psychiatrist, consultation liaison psychiatrist, and neuropsychiatrist, so just a little bit of education there. She has developed an interest in telehealth as part of several projects that included working with, through, and around all of the pre-pandemic rules and regulations. And she was a fantastic partner in crime in that project. And so I'm delighted that she has maintained an interest in telehealth even after all of that. She is looking forward to applying these lessons to her new grant-funded project that which she has already launched, a traumatic brain injury behavioral health echo program, which we encourage you to attend. And if you have questions about that, we can put that into the chat as well. So with that, I will turn it over to Dr. Erickson and let her give her talk.
Hello, everyone. With that intro, I guess I better do a good job, huh? We're going to talk about crisis management and risk assessment, and I'm going to give you kind of a paradigm and thought to think about at the beginning, and then we're going to revisit it at the end. These are our learning objectives today. I will not read them to you. Although I'm always tempted when I put up learning objectives, I will not read them to you, but we're talking about crisis management and some things to think about with that. When providers think about crises, when they think about management of crises, often we put up our hands and go, no, 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 not our clinic, not our clinic, not our clinic. We don't see those types of patients. And before the pandemic, I came across this ethics principle, this principle of medical ethics from 2013. And that's this idea that a provider shall provide support and access to the care of all patients. And I think we were really pushed with the pandemic. We were really pushed to think about this differently. And we are pushed in our clinics, our in-person clinics, to try and provide the best care and the safest care that we can for everyone. And there are some challenges and logistics around this. And I mentioned both in-person and tele because I believe fundamentally a lot of us have worked in in-person clinics that have helped manage patients that are complicated, that have helped manage these crises. And what a lot of the work that we need to do when we think about crisis management and these acute things that have come up is to put in the work front end. What did we do in these in-person clinics, and can we preemptively plan that a crisis will happen? A crisis is only a crisis if you don't plan for the potential of a crisis. I realize that seemed like circular thinking, and sometimes it is, but not in this case. Just a review of telepsychiatry. Current telebehavioral health, although we may be seeing this change over time, really got its boundaries pushed with the pandemic. If you look at pre-pandemic, what people were seeing via tele, that was pretty narrow. Cara mentioned that we've been partners in crime for a while. I've been doing telemedicine at UW since I came here 7 years ago and had some experience before then. I used to say that I did telemedicine before telemedicine was cool. Now I say I did telemedicine before telemedicine was required to actually see patients safely. So it's been going on. And as we've done that, we've pressed those boundaries out. We're seeing more complex symptoms and presentations. I think everyone is seeing that now. I am shocked and impressed. Shocked at how sick everyone is and impressed at how much people are doing in the community to try and right themselves. We're seeing at more locations. Most tele programs, if you go back 6 years ago, were not going into patient homes. And now we routinely do that. And there's potential for more encounter variables and more chances for crisis situations. Just again, highlight, we've moved beyond, typically when we think of control, we think of inpatient having the most control, outpatient have less control. And then tele is potentially a step even less control. And so that's kind of the world we're living in at the moment. And that should shock no one when I say that, I hope. Just stating the obvious. So crisis situations. As we've taken these steps out, there are three kind of big buckets that I want to highlight for crisis situations. And there are three buckets that everyone who's done outpatient care in an in-person setting has faced and has clinics that have faced and have protocols in outpatient in-person clinics that should be extrapolated from. One is medical emergencies, and we'll spend some time talking about medical emergencies. We'll talk about psychiatric emergencies as well, and we'll talk about domestic violence. This is not an exhaustive list. Every day that I do telemedicine, I think I come up against something new that is slightly nuanced here. And I think that is one of the things to think about when you're doing clinical practice, when you're doing telemedicine practice, is that whatever you have in place can be tweaked and should be tweaked. If you're finding that there are holes in sort of, the net, you need to patch it. And think about it from a systems perspective. But we'll start by talking about medical emergencies. So, excuse me, one more slide about this. Medical emergencies and emergencies in general can happen. Any appointment that you see, if you are seeing a patient and you're doing face-to-face encounters with a patient, any appointment can become emergency or crisis, just in general. I don't think we think of it like that, especially in our outpatient clinics, but any appointment can become an emergency or crisis. So it's really important to plan for them. Many clinics have workflows for what happens when a patient comes in and has chest pain, or has suicidal ideation, or has something else come up where you worry about them being potentially a victim of domestic violence. If your clinic doesn't have that, there are the AMA and many other organizations have workflows for how that could work, but those workflows are very, very important. And we've already figured out how we'd approach those with that. And if you have a patient who's coming in with some of those symptoms, you should have a standard, this is how we do a safety assessment if you're sitting in person. But with tele, you have to think of, again, that one step further away from in person, that one step further of what feels like control. And so as you're doing your planning, as you're thinking about your telepractice, as you're thinking about some of those patients that have come to you that have been in crisis, you have to acknowledge this uncomfortableness that is, if you have the potential for one, you have the potential for more. And you have to plan and be allowed, plan to allow these things to happen. And by that, I mean respond when they happen. We're talking about how plans can be adjusted or should be adjusted before and after, during, and in the unexpected event of that. But I would encourage everyone, this is that paradigm I was talking about before. I would encourage everyone, if you're thinking about managing crisis, you start out with, what is my crisis plan in inpatient? Or what is my crisis plan when I'm seeing someone in person? And then be explicit about how I'm modifying it, because crises happen. And how we stop them from being catastrophic crises is we know what our next levers, our next steps are. Before and after appointments, so thinking about telemedicine appointments, anyone interacting with the patient, as I said, should have access to whatever your clinic's safety plans are. If you're bringing someone who's onboarding for tele, if you are bringing a consultant, if someone's doing tele offsite, they really need to have access to whatever the clinical safety plan is, much like we would if someone was working and moving into our clinic physically. That includes handoff protocols for calls. If someone's calling in suicidal, that means, what are the emergency contact information for EMS in their neighborhood? And what are the protocols for all the emergency situations? Ideally, a provider at a clinic site should have a checklist sitting next to them that they can access, or a file on their computer that just has this is the appointment checklist. This gets back to that plan like there's going to be a crisis, be prepared, review it, but in the event that there's not, that's okay, but we're prepared if there's not. Thinking about during appointments. So before appointments, making sure everyone has access. During appointments, all appointments should start with some basic safety thing. And this is different than potentially any other physical appointment. This is that modification. What's the patient's physical address? What's the best contact number for that patient when we get disconnected? What's the patient's emergency contact? That does change. And I found that medical records are often inaccurate, especially in complex social situations. Is there anyone else in the room / house / location? And then permission to contact people in case of emergency. And then what is our general emergency plan? When I do tele, I start out with all of this information, some of which is required for billing. I'm not talking about billing today, but a lot of it's required for billing. And if this is your base, then you already have some of that, especially if you already have your plans for how you typically run through safety protocols if someone is in person with you. Also, during appointments, there's standardized information, obviously, that matters. And so getting this normally as a standardized process, practicing it over and over and over again is important. People panic in emergencies. And if someone goes from calm to a crisis, or comes in a crisis and we've known them before, they may not be the most able to provide and talk us through where they are at the moment. One of the things we can do is calm them down if they're able to, but having that information up front is helpful. Knowing where they are is key to sending emergency services. So when it seems intuitive, but just again, stating the obvious, when you're physically in a room with a patient, it's easy to sit with them or call someone else in the room and have them be sat with while you have emergency services coming. Obviously a little more complicated when someone's not physically with you. Knowing where they are, who their emergency contact is, allows us to potentially contact a support person or clue them into what's going on. All of this information can be used to support a patient in crisis, and I'll kind of talk about that in a little bit on the next slide. And I just want to be clear, even if tele evolves over time, every organization, APA, ATA, NRTRC, AMA, considers all of this information standard practice. So what you're doing is initial safety planning, and what you're doing as initial crisis management is all standard practice for telemedicine. So this isn't a shift in paradigm. This is something we should be doing, and this is how you can potentially use it in another way as well. I like to take a moment and model a conversation. I'm not going to make Cara play with me, but I could, about how potentially things run during appointments. So I always start out and say, as part of a tele-appointment, I need to confirm some information. You should be confirming what someone's name, what is your name and date of birth. Especially in Washington State and in UW, I also confirm if they have preferred pronouns or preferred name. Not a standard of practice, but one of those things that I've routinely been doing. Where are you physically located right now? And sometimes they'll give me vague answers, and I'll be like, well, do you mean this building? Do you mean that building? What's your cross streets? Are you in a car? What colored car? And you can get fairly specific without being intrusive. Is there anyone with you? Because I need to document that as part of our conversation. Is there a good contact number if we get disconnected? Do you have someone that you prefer to contact in case of emergency? And this is usually something I'm documenting pretty quickly. And then I always add if there's an emergency, the very first thing I want you to do is call 911. Ideally, you'd stay on the line with me while we do this. If you cannot call 911, I will call 911 and send them to you. If possible, we'll try and stay connected during that time and cross and communicate. And I always make somewhat of a joke about this, and we'll say things like, and I'm not anticipating this is going to happen. And now that we've had this conversation, we've decreased the risk of there being a crisis at all, to kind of make sure that this is normalized. But this is a normalized process during appointments, modeling this conversation, getting these key pieces of information. So you've done your due diligence and you've modeled this conversation. You're getting all of that for billing. There are unexpected things that come up. One of the things in psychiatry that people don't remember is that medical emergencies can happen. Medical emergencies, I've seen several. The very first patient, not the first patient, but within the first 2 weeks of me seeing someone, I had someone fall out of their chair and hit their head. I've had people, one day, I kid you not, I had someone's cat attack them. Apparently today was the day. I've also seen things fall off walls. We see a lot of people, I don't usually treat a lot of geriatric patients directly, but you can potentially see delirium. I've had a friend see delirium, someone who's floridly delirious. I had someone have to stop an interview because someone had chest pain. So my point with all of this is not to shock you, but it's, again, that unexpected. We think about, especially in psychiatry, the suicidal patient, the behavioral dysregulated patient. Remember that medical emergencies are something that you may need to prep people for. And you need to know where is the patient, and then be very systematic on what are their symptoms. So thinking about medical emergencies as part of your protocol. I just really want to hit on this because obviously I have some unresolved trauma, and this is something that I prep about. Is making sure you know where the patient are, what their symptoms are, being able to document that. Is there someone with them and you already asked all this good information? Are they able to go to the emergency department themselves or urgent care? Can they call 911? Can we expedite this? So as part of your planning process for the unexpected, do not forget medical emergencies. This is an example of a model conversation that I've had for medical emergencies. Hey, I noticed blank happened during the appointment. Again, stating the obvious. I want to take a minute to check in to make sure that we can continue safely. Are you okay? What are you experiencing right now? Can we call this person who you said was in the house into the room? Let's create a next step plan and just pulling it there. And again, that is this idea that we don't want to miss something like this going forward. Most of the time, I don't have problems with people following me. The only time that this comes up where I really have challenges if it's kind of clear that someone is intoxicated during an appointment. And my next step plan often is we need to reevaluate you at another time. But unexpected emergencies, don't forget them as part of your planning. I'm obviously a psychiatrist, which is why my picture for the psychiatry one is all sorts of weird. But the other unexpected emergencies that we think about that can come up are psychiatric emergencies. And I think these are the common things we think about, especially in mental health care, especially as part of a telebehavioral health summit. They include, but are not limited to, decompensation, suicidal ideation, homicidal ideation. Those are often the big three that we're worried about. Violence, sometimes we're worried about. I often don't include violence in this list, but that's because I'm doing tele into the home. And so if someone's becoming violent and destructive, I think of it more as decompensation, and there's less of a physical risk for me. In an ER, I think about physical risks to me. Not saying that it is not a crisis. I want to be clear about that. As part of our initial orientation, remember doing our initial appointment, there are we already know the standard patient location. We already know kind of the structure support questions at the beginning, because we asked who's at home or who's with this patient, where's the location. And we've talked them through all of the normal stuff, but this is where I mentioned that there are clinic guidelines and state guidelines about reporting and engaging. So most clinics, and this is a good opportunity if you're doing tele, have a generally pretty robust suicidal ideation intervention plan. Most of it includes keeping the patient on the line, already getting where they are, asking about crisis, asking about resources, asking about coping skills, doing a suicide safety assessment. And many of us are skilled in doing those. And it's a good moment if someone's mentioning suicidal ideation to click through that clinic guide and make sure people have it available. We're very good in most of our outpatient clinics in doing this. It is important to import that skill. It's the same thing I was mentioning before. Suicidal ideation is a crisis, but it is very much a crisis that psychiatry is planned for and knows how to handle. Same thing with homicidal ideation. And so falling back on those guidelines and going back to those skills and remembering that just because you're seeing someone via tele doesn't change whatever standard of care exists for an in-person appointment. And plan to have these conversations. Think about additional safety planning. So can we commit to going to the ER? When's a phone follow-up call? I actually often compare this to working in an outpatient setting. And when a patient calls in on a phone and leaves a message saying that they're not doing well, it's very much that same approach. How do you talk with a patient about how they're not doing well when they're not there with you? Same thing with tele, and it should be planned for. Some additional safety planning. I mentioned that was something. These include distress tolerance skills. I find that they're very, very helpful when talking with patients who are having psychiatric emergencies and they aren't there with you, and you actually can take time to model them. So thinking about additional safety planning, such as who can you call if you were distressed? So you're by yourself right now. Are there other people that we can rally to your support? Do you have access to the regional crisis number, which typically, depending on where you are, providing specific crisis numbers and or appropriate follow-up is standard of care, but making sure that whoever is calling and whoever's doing tele has access to those numbers and know where the patient's sitting is really important. I always ask for access to firearms and pills. And if someone has access to firearms or pills, I will specifically include that as part of our conversation, especially if there's someone else who's sitting with the patient. Is there someone or someplace that those can be moved to that are less accessible? Or can you move yourself to someplace that's less accessible? Are you comfortable in calling 911? Are you comfortable with me calling 911 if this is an acute emergency? And then we'll wait on the line and call together. And I've definitely gone to that place where I've called people during tele appointments, called 911 for someone, and we sat on the phone till that person showed up. Also thinking of additional safety planning, we can do a lot of distress tolerance skills. So there are many patients that we're now seeing who have chronic suicidality, and suicidal ideation comes up. It's one of the symptoms we treat. So I'll also ask patients as we're doing safety planning, assuming this is not an acute crisis where I'm calling 911, what do you do to relax? What do you do when you're distressed? Can we try some of these things right now? And this is actually really helpful when you're on tele, because much like when you have someone sitting with you, you can have them run through some of these skills like distraction. Can they pick up something and fidget with it, right? Can we bring the conversation someplace else? Replacement. Hey, some people feel like they're more in control, especially when the world's loud or they're having suicidal ideation, by holding an ice cube in their hand or putting a rubber band around your wrist. Let's do that now. And there are things that you can't necessarily do in an outpatient clinic. I do not have an infinite number of ice cubes. I wish I did. My drinks would always be cold, but that's not the point. I don't necessarily have rubber bands in the room, but especially people are calling you from home, they may have these things. And one of the strengths in this situation, by accessing these self-soothing techniques and modeling it, you're actually teaching them in the home how to do this, where they have all of these resources available, and it's not a one-off. So you're slowly teaching people how to self-soothe at home. If I'm not sending someone, even if I send someone emergency services, I want to set up a plan of how frequently I'm going to check in with people, much like an outpatient who is struggling, who's having crises, mental health crises, who may have chronic suicidality. I want to have a standard check-in schedule with them to make sure they're doing okay. And that's part of my planning. So again, much like everything else, we have this robust outpatient plan for people who are in person. We can do a lot of those things via tele. And as part of those things that we can do via tele, we can actually model skills with patients. And I think that's one of the real one of the real gifts that tele gives us, is that we can actually reach into people's home and have them practice where they're getting distressed. So hopefully I sold you on managing some psychiatric emergencies in the home with tele. One of the other unexpected things that comes up is domestic violence. I feel like I'm talking really fast. We'll try and slow this down a little bit, because domestic violence does come up. We are always screening for patient location. We're always trying to get a number, and we're trying to inquire who they're with. As part of my standard assessment, especially if I'm getting a feeling something's going on, and I'll explain what I mean by getting a feeling. The other questions I want to ask as part of my screening for domestic violence is that I have some set things that are right there. And that includes, is it safe for you? Or are you able to talk right now? And that usually, are you able to talk right now? Is this a safe place? Safe can sometimes be a triggering word depending on the situation. I will say, are you ready to talk right now? And I'm watching my patients to see if their eyes are darting around the room, or if they're staring at someone, or if someone's reaching over and trying to grab something from the camera, because I'll get an idea that something's going on. I'll also ask the patient, what information can I safely leave you on a phone call? Are there boundaries or barriers to this for you? Especially if I get the impression that they're able to talk freely. Some patients I've worked with who have had domestic violence, they don't want their partner to know that they're talking to anyone. And so I can call, and by anyone, I mean particularly mental health care. So I can call and say, you have a doctor's appointment, or you have a lab draw. But I can't necessarily say, this is Dr. So-and-so. We're here to check in with you. So knowing that's really important. Are there times or places I should not call you? Specific numbers, specific people to outreach to, really important. If you can't openly document that in Epic, say you're worried that someone has a partner who can access Epic, you can leave that as a little note for yourself. Many of our electronic medical records have non-publishable notes that are just internal for internal use, either for the clinic or for a particular department. So something to look into. Again, are there times or places I should not call you? Are you able to clear your call or browser history? If there's someone who's worried that they're they're being followed, or by that, I mean, they're being potentially controlled by their partner. Once you're done with the phone call, I'll encourage them and I'll tell them how to clear their browser history so that if this is something that is potentially triggering violence, they can just remove all of the information that exists. Or if they're planning to leave, being able to clear the browser call history, if they're calling shelters, or looking up domestic violence resources, can be really, really helpful and can be an additional layer of protection for them. The other thing, just as a sidebar, the other thing I will do with domestic violence situations, these are patients that if I get the impression that someone's sitting in the room with them, I will come up with a valid reason that I need to evaluate them in person if we need to have some of this conversation live to prevent some of these other issues. So, such as, I actually need to do this paper and pen test with you, like a MOCA to screen, or I really need to get this PHQ-9, or I really need vitals for this particular medication. Can you come into the clinic on this date? And I will negotiate with that patient, because sometimes you have to have some of this conversation live and see some of this and give them some breaks. All right. So we talked about what happens before an appointment. You're getting everyone who works with you all of the correct protocols for what people should be doing for and standards of care around suicide management, around homicide management, around medical emergencies. You've handled the crisis in appointments. And now we're thinking about, again, before and after appointments. Just highlighting this again, anyone interacting with a patient should have access to the updated safety plans. So if you've had this moment where you're like, what are my suicide safety plans or phone handoff things? This is your reminder to go check on those things. And not tongue in cheek, every few years when I'm prepping slide decks like this, I also have to go, where are the safety plans and what are the handoff protocols? What does this actually look like? Is it time to update them? I think of it as if we're hiring someone new and I, as someone who's been here for 6 years, doesn't know what we're doing, then probably it's time for everyone to figure out what we're doing. So what are the handoff protocols for phone calls? Again, making sure that everyone has contact numbers for EMS, protocols for emergencies, because the plan is always to plan for emergencies and know how we should interact and get people plugged in. Emergencies can and do happen, and they're only crises, emergencies, catastrophic events if we don't have planned. And suicidal patients are things that we see in psychiatry. Medical emergencies can't be seen in psychiatry. Ideally, I prefer checklists, but providers who are doing tele appointments or people who are doing tele-facing things should have an access to appointment checklists about what information to gather, who to see, all of those things that you need to for billing, and any safety questions that are typical, things that they can screen. Because the first time anyone ends up as a clinician in a crisis, sometimes our mind goes blank. And so it's nice to have those prompts. These are my references. I talked really fast, Cara, and I think we have lots of time for questions. And I think there are a lot of questions. But if I could just plug one more thing, is it really just hit on that again. Crises can happen, and you need to take the time to plan for them and be very thoughtful about that. And we have great outpatient resources that have happened before. And so there's actually already a plan. Just adapt for tele.
Very good. Thank you, Jennifer. That was a great talk. I'm going to read just a couple of comments that came in through the chat during your talk. When you were talking about ice cubes, I also recommend freezing lemons chopped into quarters, reduces the risk of being too cold and still have the temperature change response skill use.
Ooh, that's brilliant. I love that. I'm going to steal that. Thank you, whoever wrote that.
And then the same person says, another way to approach that I find helpful. I ask if on video, if they can show me their environment so that I can get a better sense of them and their environment. That can help identify if anyone else is in the immediate space. I have received a lot of positive responses of asking that from my clients, as it shows curiosity toward them and their life, parentheses, and for me to check for safety.
That's a great idea. I will do that as well. I will ask about objects I see in the room, because I obviously have a Zoom background. There's a really boring office that's like voluminous behind me, but neither here nor there. most patients do not have Zoom backgrounds in. And so I will ask about paintings on the wall or things like that. I love seeing their pets, even Ninja Kitty, who took someone out. I think it shows curiosity, and it also decreases some of those barriers and that weirdness of talking on telly.
Right. Let's see. How do I call 911 and get transferred to the patient's location if I'm in Seattle and the patient is in Yakima, for example?
I would definitely know the local numbers, because sometimes there are local numbers for Yakima. If you call 911, they should be able to provide you that, but I know that Seattle's numbers are backed up. And I know that because I've had to do reporting in Seattle. I would absolutely Google the emergency number for Yakima. You can always call 911 and they should be able to transfer you, get you the number, but if it's an emergency, I would just know that.
Right. I know there's an E911 and Brad Felker is more of an expert on that.
Yeah, Brad would know better than I would.
That's kind of one of those things that it's
the VA. So I'm talking usually about my stuff, but the VA is also weird because they can do tele across state lines. Right. And they have to know that stuff.
Right.
But there is an one. Yeah.
Comment, I put this into my initial documents prior to seeing clients, have them list their in case of emergency to include local police number and such.
Yep.
That's a good
that's a great idea.
How do we foster a more open, non-stigmatized environment for therapists to support each other when they've lost a client to suicide?
That is a great question. And I think it's one that we spend a fair amount of time talking about, even with our trainees here at UW. I wish I had an easy solution besides destigmatizing loss of suicide or suicide. I know that would be my ideal world, that we could talk about all of these things and there are support. I do know that I don't know the resources off the top of my head, but there are support groups where you can potentially go and talk about patient loss that exist for mental health care providers. But it is a problem. I will acknowledge that. And building a good community that is able to have those conversations, I think is one of those preemptive things, one of those things that I'd work on. I wish I had a direct resource for you. I do.
Yeah. Another question, what are the most challenging issues that you clinically address with consensual non-monogamy? What resources do you find helpful?
That is a really complicated question. I do not claim to be an expert. I have seen patients who are polyamorous or in consensual non-monogamous relationships. I think the things that come up are often trust, and not just trust, but who trusts who with what information. And so much like when I'm doing an initial evaluation, I'm asking, who are your emergency contacts and who can I talk and who shouldn't I talk to? I spend a little more time talking about that and the relationship and who is that person I should be speaking to, and making sure that we're very clear in the consent. I think the challenge I will run into, especially in some of those relationships, is that there tend to be a number of others who the romantic nature or complicated nature of that relationship seem to think they have access to whatever the patient is doing. And that's why I always go back to the patient and I focus on what is the patient's preference? What do they want to do? And if things are coming up, I will go back to the patient and say, hey, you're the patient. What are your goals around this? Who should I be talking to, if anyone? Who should I go back to? And if there's concerns, I will sometimes talk about clearing browser history, knowing some of the boundaries there. But I think that's where it comes down to the complexity around trust.
Wait, there's a couple of comments after that question within the Q&A agreeing with what you said. One person said she found a book to be, or she or he found a book to be immensely helpful. The author is Rhea, R-H-E-A, last name Orion, O-R-I-O-N, and the title is A Therapist's Guide to Consensual Non-Monogamy, Polyamory, Swinging, and Open Marriage. So there's a resource for you. And then, what do you recommend for those who have current suicidal ideation and self-harm behaviors when it comes to telebehavioral health?
So those are patients who, much like I would with an in-person, I spend a lot of time talking about safety. I spend a lot of time talking about safety planning and distress tolerance skills. And then I'm very upfront about, we can try it this way. And if you don't follow through with reaching out at this time, if you disappear, this is going to be my stereotyped response, which is typically, I will call 911, I will call you back X number of times. Making sure that you're safe, focusing on their safety. So I'm very upfront about how I'm going to approach this. If they are actively suicidal with plan or intent, I make it very clear that tele and doing this therapeutically in the setting is not what the next step needs to be. The next step needs to be an emergency care or an emergency visit to get stabilized. But if it's not that acute, then I will sometimes work on those distress tolerance skills. I realize that's sort of an answer, non-answer. But I think if someone is actively acutely suicidal to the point where you would really recommend hospitalization if they were sitting in front of you in person, you can absolutely really recommend hospitalization and also negotiate with that patient about what is the next step and where they're going and how to get there. So if they're not willing to go, if they're not safe to drive by themselves, can someone go and get them? And can we call that person together, right? If they need emergency services to go and they're not willing to call, can we call emergency services together? But I think the most important thing is knowing what's your follow-up plan and being very upfront with the patient about, hey, this is our follow-up plan. I want to check in with you on this date and this time. If you no-show, I'm going to worry about you. I'm going to try and call you back. But I will also send safety to go someone to do a safety check on you because I want to make sure you're safe.
Okay, great. Just a couple of comments about appreciating your talk and the conference. So just share that with you. And then, okay, this, you may have really addressed this, but I'm going to read the question anyway. Any advice on how to navigate chronic homicidal ideation? Washington's vague language around duty to protect any foreseeable victims versus identifiable can be challenging for our clinicians to navigate. Who is foreseeable? Is this legally defined anywhere with more specificity? How can we reduce our own anxieties when working with these clients who may pose risk but pose them consistently?
I want to first respond to your first part of the question by saying, yes, it's vague. And I can tell you that anytime I end up with one of these patients, even at any of my UW clinic, it's a call to risk management for me. I want to know what the boundary is, and I want to know how my healthcare system is interpreting those laws right now, because they're the ones who are going to back me. And so I realize that's a little bit of a cop-out, but also they're the ones who are backing my medical insurance. It tends to be a very evolving legal issue. So the very first thing I would say is involve risk management. And also, this is someone in your clinic that you need to have real conversations with all the providers about what we should be documenting going forward about their risk. I do not know of a clear place that is written about the duty to warn and the chronic duty to warn. It was kind of a huge mess a few years ago. I guess it was 8 years ago now when they created an even vaguer thing. This is one of those issues I keep up to date legally on. I think one of the things that you do is you create, with hopefully risk management, with hopefully all of these contacts with legal, a standard assessment that you're going to be doing and standard documentation that you're going to be doing. And when someone crosses that, hopefully it's an A or B thing. They're either on this side of it and its documentation process is normal, or they're on that side of it and it's time to call for duty to warn again. These are tricky and it's a whole topic of and of itself. So I'm going to stop talking about it, but this is one of those things that I reach out to risk management about all the time.
Yeah. Great. Any recommendations for when many of your patients have suicidal ideation, but your schedule is too full to get them in for those check-ins that you mentioned?
If you have any sort of support staff, nurse that you can call for 5 minutes, have them call for 5 minutes, I think that that's really, really helpful. And so even if it's a simple check-in, I will sometimes have these patients message me and make sure that they're reaching out, so they can leave potentially a chart message and say, yep, I'm fine, I'm checking in, I'm doing okay. I would prefer to do a full assessment. I would prefer by yards to be able to revisit distress tolerance skills and get them in my schedule. But even having someone keep a hand on them can sometimes be helpful. Did we hear a reach out from this person today of some sort?
Great. If you have weekly therapy sessions, how do you modify your beginning of session questions? Can you modify them?
Yeah, I think it's always important to establish where someone's sitting. You can shorthand those things. And so my second appointment, especially if I've seen someone in the last few months, I'd be like, hey, good to see you. I'm confirming your name and date of birth. Are you at home today? It looks like the same painting behind you. Anyone else in the room with you today? Oh, is your cat there? Cool. Hi, kitty. And so you can shorten it and be friendly and conversational. Almost like when you've gotten used to someone, you're like, hey, I really like that top. That's the top that you like to wear. Oh, is that the necklace your son gave you? And so you can shorten it. But I think the key bits of information are confirming they are in the same place that they were before. The address has not changed. And that their phone number emergency contacts haven't changed, and that the contents of their room, ideally the breathing organic contacts of the room, have not changed either. So you can get really short with those things. But you need to confirm where they're sitting and their emergency contacts, period.
Good. Do you have any recommendations for CEUs for enhanced, I don't know what these stand for, SP/RA/CM? And if it could be for psychologists, that'd be an added bonus. I have yet to find solid training, and we have to regularly.
That's a Brad question, I think. And if it's not a Brad question, so the short answer is I do not off the top of my head know of resources. I think it's something that we could take to NRTRC and ask them, because I don't know. Unless you know, Cara.
I don't. Just a comment here. I had someone have a new onset seizure in my office. I was so glad she was in person. Also, one patient came into appointment stating she had had a car accident, had swelling on her face, and I looked at the care and the windshield was cracked. Sorry, the car. And the windshield was cracked. I've been doing telehealth for 3 years and haven't encountered an emergency, but I know it can come any day now. Thank you for this lecture.
Yes. Plan. Please plan.
Yeah.
I also described this lecture as don't be me, because I definitely did not plan initially at the same level as I do now.
Yeah. Let's see if I am missing anything. What are your most commonly used distress tolerance skills?
If someone's acutely having a panic attack, I typically go distraction. So if someone just cannot hear me, I'm like, all right, with me, count how many straight lines there are on the walls. 1, 2, 3. Can you count the computer? 4, 5, 6. And we'll try and slow them down. And then often I go to rubber bands. I think of the senses. So is there something in the room that they can slow down and smell? Do they have a candle or something that they can slow, breathe, and smell? Is there something that they can touch? Do they have a blanket? Do they have a pet? Can they, again, ice cube or now frozen lemon slice is now going to be my thing forever. Thank you, person. Is there something that they can taste? Can they take a slow sip of water? So I often try and do grounding stuff with them, and that's where I go. And we can experiment with that. The other things I'll do is breathing techniques. Breathing techniques are very easy to model via tele. And so that tends to be where I go to.
Great. I lost track of time. We are a couple minutes over the session. So I want to wrap up and thank you, Dr. Erickson. In the chat, there's lots of thank yous and excellent presentations and things like that. So your audience appreciated it also. So great talk. All right. Thanks, folks, for joining us. Thanks, Jennifer.